All right, so we're going to talk about pure tone audiometry, which is like the standard part of the audiological test battery. The purpose of pure tone audiometry is to help the audiologist figure out the type of hearing loss and the extent of the hearing loss. So type of hearing loss, remember we have sensory neural, conductive, or mixed. And the extent, a hearing loss could be mild, moderate, severe, or profound. So the audiologist does this by looking at a few things. First off, the equipment needs to be calibrated. So the equipment that the audiologist uses, mainly the audiometer, needs to be working properly. So every year, audiologists have to get their equipment calibrated, where an outside company comes in and it tests the devices to make sure that the output of the devices are true to what it is saying. Another factor is the test environment. You need to be in a quiet environment so you can get an accurate reading of someone's hearing. The patient's performance is important, so the patient needs to know what their role is in the hearing test, and they have to pay attention, and they have to, participate wholly. And finally, the examiner or the audiologist needs to have an understanding of what he or she is doing. So it's not hearing that we measure. What we're actually measuring is a person's response to a set of acoustic signals that we interpret as representing hearing. So, a person with Alzheimer's might hear, but if their brain isn't making sense of what is happening, they're really not understanding. They're not hearing as we want. So pure tone audiometry, it is what it is. It's pure tones, like the frequencies that you learned about in hearing science, 500 hertz, 1000 hertz, 2000 hertz, just pure sinusoidal, simple waves are being sent through an audiometer to a person, and the person is responding. So over here you see you have an audiologist sitting at her audiometer. So what we're going to do is you're going to do a threshold search, and you're going to find the lowest level that a person can hear at, and then that lowest level is compared to established norms. And if you remember from the last chapter, there are two ways that we test hearing. We test it through air conduction, which tests the whole system, the outer ear, the middle ear, and the inner ear, and bone conduction, which tests just the inner ear. When we're testing air conduction with headphones or insert earphones, we're testing a range of frequencies. All of these are pure tones, so remember they're simple sine waves. 250, 500, we can test all of these frequencies from 125 to 8000 hertz, and we test a range of intensities from negative 10 decibels, which would be very, very, very soft sound, up to 110 decibels, which would be a loud sound. The range of frequencies tested for bone conduction is slightly smaller. You can't test beyond 4000 hertz. And the maximum level that you can use when you're testing with bone conduction is also less than air conduction. Because if you remember, bone conduction tests just the inner ear. An oscillator, a vibrator, is put on the mastoid part of the person's bone. Therefore, you can't raise the oscillator to a very, very high level, because if you raise the vibrator to a very high level, the vibrator ends up vibrating so loudly that the person can actually feel it, and you're not getting an accurate response if a person can feel a response, the vibrator moving, as opposed to actually hearing a response. So for bone conduction, we don't test as many frequencies, and the bone conduction oscillator, the vibrator, doesn't go up to very high levels. This is what I just said. Yeah, if you go up too high with the bone conduction oscillator, you get harmonic distortion. So that's why we can't go to very high frequencies with bone conduction, because the sound no longer becomes pure tone. It gets distorted. And the higher intensity you use the bone conduction oscillator, the more likely the person is feeling the stimulus instead of hearing it. Your test environment. Obviously, when testing someone's hearing, you want to have a very quiet environment. Any background noise could affect the audiometric results, and they could falsely raise the auditory thresholds. So you could have screening failures. For example, let's say the school nurse is doing hearing tests for first graders. If she were to do the hearing test in the cafeteria with all that background noise, it'd be harder for the children to hear the tones and they'd be more likely to fail, as opposed to doing the test in her office, which is quieter, where there's less background noise, less noise to mask the tones, and you would be more likely to get a valid result in a quiet environment. So there are a few ways that we can lessen ambient and background noise. You could use special headphones, you could use insert earphones, and you can use sound-treated chambers. Standard audiometric headphones aren't always the best. There are a few issues with them, and they're very commonly used because they're easy to use. There's nothing disposable. You can just put them on someone's head and then wipe them with a disinfectant pad and test the next person. So they're cheaper than using insert earphones, but they're not the best. They could be heavy and uncomfortable for children or older adults, and they could allow for background noise. So the best way to test pure tone audiometry is with insert earphones, and you'll see that in the video that I asked you to watch. They're using insert earphones where foam plugs are put directly into the ear, and this helps lessen the background noise. Plus, they're more comfortable for children, and they're more comfortable for older adults. Older adults also, if you were to put heavy headsets on their ears, it would pull down their ear canals, and it might create a false conductive hearing loss. So there's no such thing as a soundproof room. That's like impossible to remove sound from an environment, but there are sound isolated chambers, which is what we use to test hearing, and these are meant to keep noise below the level of the background noise, to make the room as quiet as possible. So there's a few ways this is done, and if you've done your observations yet, you've seen this, that the rooms where the testing is done, and they're maybe raised off the ground, so you step into them. They have very thick walls with insulating materials and carpets and like holes in the walls, and there's foam in the walls to absorb the rooms. Soft materials are used just to keep any sort of reverberation or background noise at a minimum. So there's no such thing as a soundproof room, but there are sound isolated rooms where hearing is tested. Usually there are 2-room suites, so very rarely would you see a 1-room suite where the examiner, the equipment, and the patient are in the same room. Usually they are 2 separate rooms, and they're divided by a wall, and there'd be like a glass so the patient can see the audiologist through the wall. The equipment and the audiologist are in one room, and the patient is in the other room. So the best testing method is you either use earphones with attenuation devices or cushions on them. Insert earphones are best, and then there's the sound isolated chamber. The patient's role. So remember, we spoke about the equipment needs to be calibrated, the test environment needs to be quiet, and the patient needs to know what their role is. So patients coming for hearing tests, they have very different motivations. It could be a 2-year-old coming to rule out hearing loss as a cause of language delay, or it could be an older adult whose wife made him come in because she's tired of repeating herself. There's different education levels and there's different motivations. For example, the man whose wife is making him go in might have zero interest in being there and not the most willing to cooperate. Young children could also be challenging to test, and when you test young children, you have to have 2 audiologists in the booth. So your test approach is going to be different for audiologists and children versus adults who are cooperative and children who are frightened and shy, and your procedures are going to vary depending on the spoken language that someone has, their ability to speak, and the language that they use. Sometimes written communication is necessary, or gestures or demonstrations, depending on the person's degree of hearing loss. So the patient has to understand what is expected of them. They need to know that every time they hear a tone, they're supposed to raise their hand or signal that they heard it by pressing a buzzer. Or some cases, maybe with young children, they'll just say, I hear it. So what you're doing is you're searching for the threshold of hearing sensitivity, the lowest level at which a person can perceive a sound. So barely audible, the threshold, the lowest level that a person is able to hear sound. False responses might be heard sometimes, and these could cause errors in your interpretation. So the more experience you get testing someone's hearing, the more you're going to be aware if there's a false negative or a false positive. So with a false negative, a patient fails to indicate that they heard the tone. So in this case, maybe they didn't understand the directions, or maybe they zoned out. With a false negative, it makes it look like their hearing is worse than it actually is. So maybe someone's lying, or someone wants you to think that they have a hearing loss and you really don't. So even though they hear the tone, they're not raising their hand, or like I said, they could have just zoned out. It's very, very hard to fake a hearing test. It's such a subjective thing at different frequencies to like match up ear for ear, and to consistently fake a hearing loss at a different level. So an audiologist should be aware if someone is trying to fake, because it's really impossible to do. But a false negative is when you're sending a sound in and they hear the sound, but they're not responding that they heard the sound. False positives could also occur, especially if there are long periods of silence when you're testing someone's hearing, where a person thinks they hear a sound, but they don't. So what the clinician is going to do is they have to be very clear with the instructions. So the clinician would say, you're going to hear a series of tones, first in one ear and then in the other. When you hear a tone, no matter how high or how low in pitch, no matter how loud or how soft, please signal that you have heard it. Raise your hand when you first hear the tone and keep it up as long as you hear it. Put your hand down when the tone is gone, and remember to signal every time you hear a tone. So even if the sound is very, very soft, they probably hear it, so they should raise their hand. And then you say, are there any questions? And you go forward. Sometimes you could provide written instructions in the waiting room, or, to help someone understand their role in the test. Now, when you're testing someone's hearing, the patient shouldn't be able to see you. So the patient's not going to be facing you directly through, the glass, because any small eye movements or hand movements or arm movements is going to sort of like clue the person in that you're sending a tone in or you're raising a level in. So you want the patient to not be facing you, but to have their side to you, so that they can't catch those little movements. And this is true for children too. They're also very perceptive of any movements. So you want to make sure that the patient can't see what you're doing. Okay, so going back to our pure tone audiometry, we have the environment set up, the patient knows their directions, and the equipment is calibrated. So pure tones are going to set in, and we want to find the person's threshold, or the level at which the tones are perceived as barely audible. We did this. We made sure everything is calibrated. The equipment works. It says the frequencies it's supposed to say, it says the intensities it's supposed to be set, and that's that. So we're going to start with air conduction. We're going to start testing the whole system. We'll have the earphones on, or the insert earphones, and we're going to test the outer ear, the middle ear, and the inner ear by sending sounds in, by sending the pure tones in. With air conduction, we could figure out the severity of the loss, but we can't figure out where the loss is. We can't figure out if it's conductive, sensorineural, or mixed until we do bone conduction. Remember, that's why we did both air conduction and bone conduction, because testing both ways helps us pull out, separate the system and figure out where the issue is. So a headband is placed directly over the person's ears. You push the hair away, you remove earrings, because sometimes the headsets could be uncomfortable for someone who's wearing hearing earrings, you make sure the diaphragm of the headsets is placed directly over the openings of their ears. Like I said, inserts are always better. They're better for older adults who might have collapsed ear canals when you put heavy headsets on them. They're better for kids. They're more comfortable. You don't have to worry about the occlusion effect, which we'll talk about. So in general, inserts are better. You just sort of squish them up and you put them in the person's ear and they expand. So for testing air conduction, we begin at 1,000 hertz. And then we go up and we test the octaves. So we test 1,000, 2,000, 4,000, 8,000. We go back and we recheck 1,000, 500, 250 hertz. If there's a difference between, say, 1,000 and 500 hertz of 20 decibels or more, then you go and you test inner octaves. So we test 750. Or if there's a difference between 1 and 2,000 hertz of 20 decibels, we would test an inner octave at 1,500 hertz. So we begin testing at 1,000 hertz because this is a frequency that is easily heard by most people and it has high test-retest reliability. If a person comes in with a severe hearing loss, so if a person's having a hard time understanding you in the waiting room, and you suspect that they have sensory neural hearing loss or presbycusis, you could start at a higher frequency. You would start at a lower frequency than 1,000 hertz. Maybe you'd start at 250 or 500 hertz because the higher frequencies would be harder for a person to hear. We tend to lose our hearing first in the higher frequencies. So if a patient comes in with a very severe hearing loss, you would start at like 250 hertz or 500 hertz. So with pure tone audiometry, we start at 1,000 hertz at 30 decibels. If the response is obtained, then you can start your threshold search. If no response is obtained at 30 decibels, so you're sending in 30 decibels of sound, that's the level of the sound going in at 1,000 hertz. If the person cannot hear 30 decibels, you go up to 50 decibels. If they cannot hear 50 decibels, you go up in 10 dB steps until you get a response.